Assalamu alaikum everyone. My name is Shahd Alheijani. I'm a third year medical student, and today we'll be going over HNS pathology. So this session, inshallah, is going to be a review session. So we'll be solving questions. But I believe it will be helpful if we can go over all HNS pathology. Just a quick review to refresh our memories. Tamam. So in this lecture, we'll be going over oral cavity, salivary glands, dental diseases, and the larynx and the nasopharynx. So um, there's a question. Okay. So starting with this summary table I made back when we were in second year. It has all the most important points about every disease in HNS pathology, with the main gross picture, the gross appearance, and the histology. So I think it would be helpful to go over them before starting the session. So 1 second, let me share the actual table. تمام. Yeah. So you can stop me anytime if you have any questions. And Bismillah, we can get started. Okay, starting with the lesions of the oral cavity. So we have several regions. Let's start with the simplest one, with the most obvious one, which is the aphthous ulcer. An aphthous ulcer is basically just a shallow ulcer surrounded by hyperemia. It's very common. It's basically, yes, very common. It's superficial and linked to stress levels or vitamin deficiencies. The main finding here is lymphocytes and neutrophil infiltrates. It's most common in females, especially in the first 2 decades of life. And there is no specific treatment for it. It's just any symptomatic treatment would be, any symptomatic treatment would be enough. So this is the most common and the simplest oral cavity lesion. Moving on to the herpes simplex virus ulcer. Now, one most important thing to remember is that you have two. You have HSV1, HSV2. One is related to oral lesions, two is related to genital lesions. One important thing to remember about HSV is that it is a latent virus and then it will get reactivated. So primary infection will be asymptomatic. The patient won't have any symptoms. And it's basically a spectrum. So it may range from any asymptomatic lesion to acute gingival stomatitis, which is basically inflammation. Now, the patient would first be exposed and the virus will be latent in the nerves. And then later on, the virus will get reactivated when the immunity drops. And when the immunity will drop, the virus will get reactivated, and it will cause stomatitis, labialis, or a cold sore, as you can see in this image. So the lesions will appear as small ulcers, and basically, the management will be taking a biopsy or a sample to the lab. So this is the gross appearance, and this is the histology. Now, it's very important to remember the histology of the herpes virus. The most important findings in herpes is the multinucleation, the molding, and the margination. So this basically describes the appearance of the nuclei in the cells. So here you can see one cell will have multiple nuclei, have multinucleation, margination, and molding. So they will be pushed inside the cell, and there is molding of the nuclei together. So the cell will look swollen with eosinophilic intranuclear inclusions and multinucleated giant cells. So this is all for herpes. Now, moving on to candidiasis. Candida is basically a fungal infection. So fungal infections usually appear as white patches or a pseudomembranous thrush, as you can see here in this image. Can you guys see my cursor, or do you need the pointer? Does it look good? Okay. طيب. This is Candida. It will appear as white patches, and the most important thing to remember is that it's scrapable. So in other lesions, as we'll see in a bit, you won't be able, if you try to scrape off the top layer or this white layer, it won't come off. But in Candida, one important thing to remember is that it's scrapable, so you can remove this layer. And when do you get this infection? You get it in immunosuppressed patients or patients with altered oral microbial flora. So if the patient is immunosuppressed, in which cases do we get immunosuppression? If the patient is hospitalized, a patient has a severe chronic disease, for example, in this case, the patient will have a drop in the immunity, and this will cause some infections to be able to take over. In this case, it's Candida. The infection will be Candida. And it's the most common fungal infection in the oral cavity. Now, moving on to the fibroma. Fibroma is a tumor-like growth. So as you can see, it bulges like a small nodule. But this is a common reactive inflammatory growth. So it's the most common reactive inflammatory growth. It's not malignant. It's just due to irritation at the along the bite lines. So as you can see here, it appears in the cheek along the bite lines of the teeth. So it's due to irritation. It's not malignant. It's not an actual tumor. It's tumor-like growth. Now, moving on to pyogenic granuloma, which is again another tumor-like growth. In this case, this is basically granulation tissue. This granulation tissue can regress or undergo fibrosis. So, can anyone remind me what is granulation tissue? In the chat. تمام. Other answers? Okay. So in this case, we said pyogenic granuloma is yes. Okay. So we said pyogenic granuloma is excessive granulation tissue. Granulation tissue is basically a proliferation. So you have connective tissue and you have blood vessels at the same time. So here you can, as you can see, this is the pyogenic granuloma. So it is a proliferation of blood vessels and capillary hemangioma, and it can regress or undergo fibrosis. Now, a very classic scenario, and the most common scenario where you can see pyogenic granuloma is a pregnant woman. And a pregnant woman would present to the clinic complaining of a rapidly enlarging mass in her mouth. And in this case, the most important thing, or the first thing to think of, is the pyogenic granuloma. Now, moving on to leukoplakia. Now, what we described so far, the fibroma and the pyogenic granuloma are tumor-like growths, but they're not actually cancers. Now, leukoplakia, erythroplakia, on the other hand, are precancers. So they themselves are not cancer, but they can lead to any cancer. In this case, it will be squamous cell carcinoma. Starting with leukoplakia. Now, leukoplakia is unscrapable white patch. Now, as we said in candidiasis, the fungal infection is you can scrape off the top layer. Meanwhile, in leukoplakia, which is precancerous, you cannot remove the top layer. And from its name, leuko means white. So as you can see here, you have white patches as opposed to erythroplakia, where you can see the red patches. Now, this is leukoplakia. The most important association with leukoplakia is tobacco use. So the patient that presents and that presents, and when you take the history and you find out that the patient is a smoker, takes tobacco in any way, you should think of leukoplakia. There are many differentials in mind, but keep leukoplakia in your list of differentials. So leukoplakia is also a diagnosis of exclusion. So you'll make sure that the patient does not have any trauma, fungal infections, tumor, and so on. And then you would think of leukoplakia. Now, about 5 to 25% of leukoplakia is precancerous, and the ratio of male to female is 2 to 1, so it's more common in males. Now, let's look at the histology. Here you can see there's epithelial hyperplasia, and the most important findings you will see in leukoplakia are thickening of this layer. So you have acanthosis, so thickening of the skin. You have a thick keratin layer, which is hyperkeratosis. You can see this top layer, which is the keratin. It will be thickened, so you have hyperkeratosis. You also have nuclei in the keratin layer, so you have parakeratosis. So usually keratin is supposed to be dead skin cells, but in this case, you can see the nuclei. So this is called pyokeratosis without dysplasia up to varying degrees of dysplasia. Because we said leukoplakia is precancerous. So at a certain point, after a certain point, it can lead to squamous cell carcinoma. So as we said, leukoplakia is unscrapable, white patches linked to smoking, and 5 to 25% are precancerous. And this is the histology. Now moving on to erythroplakia, again precancerous, and it's less common than leukoplakia, but there is a higher risk of malignant transformation. So we said leukoplakia has a 5 to 25% chance of becoming malignant. Erythroplakia has a much higher risk at 50%. And we said leukoplakia is white. Erythroplakia, on the other hand, is red velvety eroded areas. So this is the gross morphology picture, and now this is the histology. So in the histology, you can see there is erosion and epithelial thinning. You have a dysplasia of varying degrees. In this case, you have severe dysplasia because the cells won't be well differentiated. We said erythroplakia has a higher chance of becoming malignant, so it makes sense that you would have varying degrees of dysplasia as it progresses to malignancy. In this case, you have a severe dysplasia. It can lead up to carcinoma in situ. So carcinoma, again, as I'll explain in the later slides, it has varying degrees. It starts by dysplasia. You have metaplasia, dysplasia, and then carcinoma in situ. So it's still in the same site, and then it will metastasize. And you also have subepithelial inflammation. So below the epithelium, you have lots of lymphocytes and infiltrates. So this is subepithelial inflammation. Now that is it for erythroplakia. Now we will move on to hairy leukoplakia. Here, let's not confuse leukoplakia with hairy leukoplakia. Leukoplakia is precancerous, linked to tobacco use. Now, hairy leukoplakia again is unscrapable white fluffy patches. We said the scrapable one was candida. The unscrapable is leukoplakia. Hairy leukoplakia is not pre-malignant. So leukoplakia can lead to cancer. Hairy leukoplakia is not pre-malignant. And as opposed to leukoplakia, as you can see in those images, hairy leukoplakia would appear on the margins of the tongue. So this is the most common, or yes, the most common appearance of hairy leukoplakia. And for histology, you will see epithelial thickening. Now, the most important thing you need to remember about hairy leukoplakia is its association with EBV. So Epstein-Barr virus is associated with hairy leukoplakia. So it is also seen in HIV patients. Now, this is due to the fact that EBV will infect the immunocompromised patients. So a patient with HIV will be immunocompromised. So it makes sense that hairy leukoplakia will be associated with EBV, and it's seen in HIV patients. Now, let's move on to squamous cell carcinoma, which is the last one for the oral cavity lesions. Squamous cell carcinoma is the most common of the head and neck tumors. It consists about 95% of head and neck tumors, and it's the sixth most common overall. Now, patients who have squamous cell carcinoma will present late. So late presentation means there is a high chance of mortality. This high chance of mortality could be due to several factors. It can be due to field cancerization or perineural irritation. Field cancerization means other than the primary cancer, you will have many primary cancers or many primary tumors or secondary metastasis. So in simple words, it is spreading. So it will have higher chances of mortality, and it will reach the nerves, and you will have perineural irritation. Squamous cell carcinoma is associated with many factors, mainly smoking, tobacco, alcohol, and HPV-16. Now, remember how we said leukoplakia is associated with tobacco, and leukoplakia is precancerous, can lead to squamous cell carcinoma. So it makes sense that squamous cell carcinoma would also be associated with smoking. So the most important factors for squamous cell carcinoma are two. You have smoking, and you have human papilloma virus. HPV-16 is associated with squamous cell carcinoma. Now, you have several types of HPV. You have the human papilloma virus of different numbers. So, for example, you have 6, you have 8, you have 16. So, some types or variants of HPV would lead to benign lesions like warts, for example. And other numbers like HPV-16 in this case would lead to more malignant lesions. In this case, it's squamous cell carcinoma. So what is the difference between squamous cell carcinoma that's associated with smoking and the one that's associated with HPV-16? Now, the one associated with HPV-16 will lead to a better prognosis, and it's found in younger patients. Meanwhile, squamous cell carcinoma associated with smoking will have worse prognosis, and as you can guess, it's associated with older patients. Now, the one associated with HPV-16 will be non-keratinizing nodal disease with small primary. So there is less risk of having a secondary tumor, secondary cancer. So just a quick recap, squamous cell carcinoma is associated with smoking and HPV-16. HPV-16 or human papillomavirus 16 will have better prognosis, younger patients. It is non-keratinizing and nodal disease, so it will spread to the nodes with a small primary. Some of the risk factors are leukoplakia, erythroplakia, and family history. As we said, leukoplakia and erythroplakia are precancerous, so they can lead to squamous cell carcinoma. Now, the appearance will be a bulging ulcerated mass, plaques on the tongue or floor of the mouth, and they can spread to cervical, mediastinal nodes, and the liver, lung, and bone. So we said the patient will present late, so there's high mortality, high chances of spreading to other organs, like the mediastinal nodes, cervical nodes, liver, lung, and bone. So here's the appearance of squamous cell carcinoma. So it can range from well differentiated to anaplastic cells. So you have pleomorphic squamoid cells, keratin pearls, and intercellular bridges. Now, keratin pearls and intercellular bridges are basically most important findings in epithelial cancers. So squamous cell carcinoma will have keratin pearls and intercellular bridges. Now, you can look at those images. So this is a keratin pearl, and these are the desmosomes, which connect the cells together. So these are the most important findings in squamous cell carcinoma. And here you can see malignant keratinocytes invading underlying muscle and connective tissue. So basically it can invade, if it's not in situ, so if it starts spreading, it can invade the underlying muscle and the connective tissue. So that is it for the first one, which is the oral cavity lesions. Do you have any questions, or can we move on to the next section? All clear? Tamam. So moving on to lecture 2, which is the salivary glands. Sorry, there's a question. I'm sorry, which one? Oh, you mean this? Okay. CIS is basically carcinoma in situ. So as we said, it can there are several stages. First, it will start by dysplasia. You have metaplasia and then dysplasia, and then the actual. So here, let's go through the images. So this is the normal skin. This is the normal oral mucosa. And then you'll have hyperplasia where basically the layer will start thickening, and you have hyperkeratosis. So you can see the keratin layer compared to this one will be thickened. And then you have mild to moderate dysplasia where the cells start changing. And then you have severe dysplasia with carcinoma in situ. Carcinoma in situ, basically, it did not invade the basement membrane. So it's still within the basement membrane, still within the epithelial layer. And then finally, it will form the squamous cell carcinoma. So here's the carcinoma in situ. It's still within the basement membrane. And here it invaded, as you can see, it invaded the connective tissue. It went down below the basement membrane, invaded the connective tissue and the muscles. Is that clear? Okay, tamam. Now we can move on to the second lecture, which is the salivary glands. Now, for the salivary glands, starting with sialadenitis. Now, this is a fluctuating fluid-filled cavity, as you can see here. So this lesion is the sialadenitis. Any itis is basically inflammation, or yes, so itis is inflammation. As you can see here, you have lithiasis. Lithiasis is associated with stones. So when we say nephrolithiasis, you have a stone in the kidney. Sialolithiasis, you have a stone in the salivary glands. Meanwhile, in sialadenitis, you have inflammation. So, starting with this one, you have a fluctuating fluid-filled cavity due to destruction or blockage of a duct. Now, this is a mucosal. The mucosal will fluctuate with meals because of the secretions, the salivary secretions. Now, if the duct is destroyed or blocked, the secretions won't be able to leave. So it will fluctuate. So the lesion or the mucosal will fluctuate with meals. Now, the inflammation is most common in the submandibular gland compared to other salivary glands. Now, it can be associated with viral infections or bacterial infections. Viral, like in mumps. Bacterial, you can have Staph aureus, you have viridans, or it can be due to other causes like blockage or dehydration. And it's usually unilateral with painful with discharge. Now, this is also associated with the Sjogren syndrome. Sjogren syndrome will be discussed in a bit, so I'll go back to it in a while. Now, this hidradenitis, which is the inflammation due to blockage or destruction of the duct, can resolve, or it can move on to become chronic hidradenitis. Now, in chronic hidradenitis, you will have fibrous tissue, and from its name, you'll have chronic inflammation. You will have acinar atrophy. Acinar are basically the structures that would release the secretions, in this case, the saliva. So you'll have atrophy of the acinar cells, and you will have residual ductal elements. So this is it for hidradenitis. This is the histology picture, and this is the gross morphology. Meanwhile, for sialolithiasis, as I said, lithiasis means stone. So here we have a stone. The stone has calcium, and it will stain blue in hematoxin and eosin stain. So this is the histology. You can see this huge stone. This is the sialolithiasis, and this is the gross morphology. And you will have lymphocytic infiltrates. So here you can see the blue stone surrounded by lymphocytic infiltrates. You don't have to know more than that for sialolithiasis. Now for Sjogren syndrome. This is very important, very high yield. You have to understand it. Now, Sjogren syndrome is an autoimmune disease. It's autoimmune destruction of the exocrine glands, mainly the salivary and the salivary and the lacrimal glands. Salivary for the saliva, lacrimal glands for the tear ducts, for the tears. Any autoimmune disease, as you will learn later on, usually most of them will be more common in females. So Sjogren syndrome will be more prevalent in females, especially females in their 50s. So it's an autoimmune disease due to destruction of the exocrine glands, and more common in females because most autoimmune diseases are more common in females. It can either be primary or secondary. Now, a primary Sjogren syndrome is also called the Zika syndrome. Meanwhile, secondary means it's associated with another disorder, another disease. In this case, it can be with rheumatoid arthritis or SLE, which is lupus, systemic lupus erythematosus. So you can either have primary Zika syndrome or secondary, which is associated with rheumatoid arthritis, SLE, keratoconjunctivitis Zika, and enlarged salivary and lacrimal glands. And finally, xerostomia, which means you have less saliva. So we said we have destruction of the exocrine glands, so you'll have less saliva. You basically have dryness in all the secretions, in the saliva, and the tears, and everything. Now, we said it's an autoimmune disease. So what is the pathophysiology? What is happening? Here, in this case, you have antibodies against certain antigens, the Rho and the La antigens. The Rho, which is SSA, and La, which is SSB. Those are ribonucleoproteins, and you will have antibodies against those proteins. So against the SSA, against SSB, and it can also be associated with HLA genes and environmental factors like viral infections. So there are several hypotheses as to what causes this autoimmune disease. It can either be antibodies, can be gene mutations in HLA, it can be environmental factors like a viral infection. Very important association in Sjogren syndrome is B-cell lymphoma. There is a 40 times increase in the risk of B-cell lymphoma with Sjogren syndrome. So this is the appearance of Sjogren syndrome. You need to get a lip biopsy to confirm. And what happens here is that you have autoreactive T and B lymphocytes. So we said it's an autoimmune disease. So you will have autoreactive T and B lymphocytes that are meant to target the viral infection or any environmental factors. But now due to certain mutations or due to any pathology, it will start attacking your own body. To attack the SSA and the SSB ribonucleoproteins. Now, this attack will be in susceptible patients due to viral infection. As we said, this is one of the hypotheses as to what causes this disease, and it will lead to cell death and the release of self antigens. And again, you will have lymphocytic infiltrates because it's autoimmune disease. Now, this is for the first three lesions. Now we can move on to the neoplasms of the salivary glands. Now, for the neoplasm, I want you to remember some few points. Smaller glands mean it is more malignant. So, which glands do we have? We have the sublingual, submandibular, we have the parotid glands. So, the smaller the gland, the more chances that it's a malignant lesion. And most neoplasms are in the parotid. Now, parotid compared to the other glands, is it larger or smaller? Type in the chat. Mm-hmm. It's larger compared to the other to other neoplasms. So does that mean it's more possible to be malignant or benign? We said the smaller gland is more likely to be malignant. So parotid lesions or parotid neoplasms are more likely to be benign compared to others. Meanwhile, sublingual is more common, which is not more common. It's the sublingual will have more chances to be malignant, and generally neoplasms of the salivary glands are more common in females. Now we have two we want to focus on, which are the pleomorphic adenoma and the mucoepidermoid carcinoma. Now for the pleomorphic adenoma, I want you to remember that it is the most common salivary gland neoplasm among all. Meanwhile, the mucoepidermoid carcinoma, as we're gonna see in a bit, it's the most common malignant. So this one is the most common overall. Pleomorphic adenoma is the most common overall. Now it's in the parotid. So we said a larger gland, the parotid, will more likely be benign. So it is a benign neoplasm, but has a very high chance of recurrence. So you can get rid of it, and it will recur again. It is mobile, it is painless, and it's a mixed benign tumor, as we said. So it starts from a myoepithelial cell, and you have the divergent differentiation. So you can see different types of cells in this neoplasm. What are the cells? So you have chondroid matrix or a myxoid background with epithelial and myoepithelial components. So it's triphasic. Now, from the name, it's pleomorphic. So it has many different constituents in this lesions. So it's triphasic. It won't be comprised of one type of cell. You'll have chondroid matrix, myxoid background, you have epithelial cells, myoepithelial components, and several things going on in this neoplasm. So, and I want you to remember that it's capsulated with tiny extensions. Why is this important? Now, usually if you have a neoplasm and you want to remove it, else if you remove this neoplasm, you made sure that all the cancerous cells are removed. You got rid of them. But in this case, you have some extensions from the capsule. So removing only the place of the neoplasm is not enough because you have those extensions. So you need to do wide resection of the tumor. So you'll remove this tumor and you have to take a wide margin to make sure that you got rid of all those extensions. Now it's also closely associated to cranial nerve 7, which is the facial nerve. So if it spreads and it reaches the facial nerve, it can cause facial palsy, which is a sign of malignancy. So we said it is benign, but there is a chance it can move on to being malignant. Now, if it reaches cranial nerve 7 and starts spreading, it will affect the facial nerve and it's a sign of malignancy. Now to mucoepidermoid carcinoma, which is the most common malignant. We said pleomorphic adenoma. Adenoma is usually benign. Any adenoma is usually benign. Now carcinoma, on the other hand, is malignant. Mucoepidermoid carcinoma is malignant, and it will involve cranial nerve 7. It is squamous. It's mucus secreting from its name, mucoepidermoid. So it's squamous and mucus secreting, and it has intermediate cells. Now, the grade would determine a prognosis. So low grade will have a good prognosis, we will have 90% chance of 5-year survival, but a high grade carcinoma will have a lower chance, which is 40 to 50% only. And this is the appearance and histology. Now, that is it for salivary glands. We can move on to dental diseases. Do you have any questions for that section. Now, don't worry, I'm taking my time with the explanation because this will help us go faster with the question. So inshallah, we won't take that long. So I'm all clear. Okay. Now, moving on to the third lecture, which is the dental diseases. Now, dental diseases, before going to the dental diseases, there are two lesions we want to remember in the beginning, not lesions. So basically, we will start with the dental plaque, and then dental caries, and then moving on to gingivitis periodontitis. So dental plaque is basically this biofilm that forms in the teeth. This biofilm you can control it. So if you take good care of your oral hygiene, you can take care of you can control this biofilm, which is basically made of bacteria, the dead epithelial cells, and so on. But if it starts building up, it can move on to calculus, and then it will form the dental caries. Now, I'm sorry. Now, the dental caries will basically have some inflammation. I mean, some demineralization. So it will start building up on the teeth, and it will start demineralizing the enamel of the teeth. So this will be the beginning of the pathology in the teeth. So first we'll start with a harmless biofilm, but it's harmless for now. If you don't take care of it, it can progress. It can form the caries, and then the caries can lead to cavities and so on. And then we'll move on to the gingivitis. Now, accumulation of this dental plaque and the calculus will lead to inflammation of the oral mucosa, erythema, edema, and bleeding. So basically, whatever is happening in the gums, in the gingiva. Have inflammation, erythema, edema, bleeding, changes in contour, and loss of soft tissue adaptation. Now, it can happen any age, but mostly in adolescence. It is related to the food habits, to their lifestyle in general. And if it's chronic, it can lead to to hypertrophy of the gums. And the most important way to take care of it and prevent gingivitis is oral hygiene, basically. So if you take good care of your oral hygiene, you'll prevent the earlier steps, the accumulation of plaque, the caries, the everything leading on to gingivitis. Periodontitis is a more progressed lesion or more progressed pathology. In this case, the poor oral hygiene with the alteration in the composition of the oral microbiome, coupled with the immune deficiency and gram-positive bacteria, will lead to this pathology, this finding here. So, as you can tell from the picture compared to this one, you can see that it will affect the actual gums, not just as inflammation. So you'll have a localized inflammatory process affecting the periodontal ligaments, the bones, the cementum of the teeth, everything suffers. So in this case, there is destruction, not only inflammation. So you have destruction in the ligaments, in the bones, in the cementum, and so it can lead to teeth loosening and loss of the teeth. So here it was erythema, edema, inflammation, periodontitis. On the other hand, you will have teeth loosening and loss because of the destruction of all those structures. Now we said it's also coupled with immune deficiency, so it can be part of AIDS, leukemia, diabetes, Down syndrome, and any neutrophil defects. So those will cause the patient to be immunocompromised, leading on to periodontitis. Now to the actual important stuff in this lecture. Now we have different cysts we need to focus on. We have the radicular cyst or the periapical granuloma. Now those cysts will have, some of them will have one or two names. If it has two names, you need to remember both because they can get either of them. So you have a radicular cyst or periapical granuloma. You have dentigerous or follicular cyst, and you have the OKC or keratocystic odontogenic tumor. Now, I want you to remember that the radicular cyst is an inflammatory cyst, the dentigerous and the OKC are developmental cysts. So just keep that in mind. Radicular cyst is inflammatory, and it's the most common cyst overall. It will be found at the root or the apex of the tooth. So a periapical granuloma, so it's named the apex. So it's at the root or the apex of the tooth. It's equally common in males and females at the third or sixth decade. As you can see, it's a well-defined unilocular radiolucency, and it's due to long-standing pulpitis secondary to advanced caries or trauma or due to bacterial irritation. So we said it's inflammatory, so it's associated with pulpitis, and Pulpitis is basically inflammation in the pulp of the tooth. So you can see here it's well defined. So you can see the line surrounding the cyst, and it's resorbing part of the tooth. So the main management is complete removal of the offending material, and then you can extract or restore the tooth. Now this is for the histology. Now, oh, sorry. Okay. So here is, as you can see, you will have non-keratinizing stratified squamous epithelium. The wall of this cyst will have dense fibroconnective tissue with acute and chronic inflammatory cell infiltrate. So we said this is an inflammatory lesion. So you will have acute and chronic inflammatory cell infiltrates. You have dense fibroconnective tissue, and it's non-keratinizing stratified squamous epithelium. So this is the appearance of the cyst. And, okay. Some questions? No. تمام. Now to the dentigerous cyst, or the follicular cyst. Now it's the most common developmental cyst. So this we said is most common overall, but it's inflammatory. Now among the developmental, the most common would be the dentigerous or the follicular cyst. Now it's more common in males, and it's around the crown of unerupted tooth, especially the third molar. So this is the tooth, this is the third molar, and it will be around, sorry, here. So here you have the radiolucency. So it looks a bit dark. So this is the cyst. As compared to this one, which was near the apex, so it's periapical granuloma, it's a radicular cyst. Here it's near the crown of unerupted tooth, especially the third molar. So this is the unerupted tooth. This is the border of the cyst. This is the well-defined radiolucency. Now, it is due to fluid accumulating between tooth and dental follicle. And the treatment is, again, complete excision. You remove this cyst, and the recurrence of this cyst is uncommon. And if in case it does recur, it's due to incomplete excision. So you didn't really remove the whole cyst. So this is the gross appearance, and this is the histology. Wait, sorry, 1 second. Here. Okay. Share my screen again. So this is the histology. You can see here, you will have thin stratified squamous epithelium, and the wall will have thin fibroconnective tissue. Compared to this one, you will have dense fibroconnective tissue with acute and chronic inflammatory cells. Meanwhile, in dentigerous or follicular cyst, you will have thin stratified squamous epithelium with thin fibroconnective tissue. And if there's inflammation, you will find chronic inflammatory cells in the surrounding connective tissue. So this is for the dentigerous. The dentigerous one is around the crown of the unerupted tooth, especially the third molar, and it's the most common developmental, as opposed to the radicular cyst, which is around the apex of the tooth, and it's the most common overall, but it's inflammatory. Now to the OKC, the keratocystic odontogenic tumor. It can happen at any age, but mostly in the first to the fourth decade, and more common in males. Location is in the posterior mandible. So here you can see this is the cyst. It's in the posterior mandible. Here we said it's around the crown of the third molar. This one is at the apex. So the OKC, keratocystic odontogenic tumor, is around the posterior mandible. Now, the way I used to remember that or differentiate that this is the posterior mandible is keratocystic odontogenic tumor. I used to think of carrots. And when you eat carrots, you need to reach the last molar, so the end, so the posterior mandible. But this one will be the third molar. The other one will be the apex of the tooth. So here, a keratocystic odontogenic tumor, or the OKC, will be at the posterior mandible. It's associated with basal cell carcinoma. And we don't need to know all those details. We'll take them in detail in third year. But for now, just remember that the keratocystic odontogenic tumor is associated with basal cell carcinoma. And since it's associated with carcinoma, so you can expect that it would be aggressive. and 80% are solitary, so it won't be multiple. Again, it will be well-defined unilocular or multilocular radiolucency, and you can treat with complete excision. Now, again, it can recur in up to 60% of the cases, and recurrence, again, is associated with incomplete excision. So here you can see you will have a thin layer of keratinized stratified squamous epithelium. You will have a prominent basal cell layer and the corrugated epithelial surface. Corrugated, as you can see here, so you can see it looks as in waves. So this is associated with OKC, or the keratocystic odontogenic tumor. You will have prominent basal cell layer, you will have thin layer of keratinized squamous epithelium, and corrugated epithelial surface. Now, moving on to odontoma and ameloblastoma. Those are actual tumors, you need to remember. So we're done with the cysts, moving on to the tumors. Odontoma is the most common odontogenic tumor, and it's a hamartoma. So hamartoma is usually benign. Hamartoma is hamartoma, basically, you have a tumor originating from the same tissue in which you find this lesion. So here it is of epithelial origin, but what happens is you have disorganized enamel and dental deposition. So you can see in this picture here, here you can see there is disorganization. They are not arranged in layers forming the proper tooth. You have disorganized enamel and dentin. So you have, it is still from the epithelial origin, but it's disorganized. So it may be a hamartoma. This is called the odontoma. Again, treatment by local excision. Now, this is extra details. You have two types. You have the compound type and the complex type. We were taught this lecture by a different doctor last year, Dr. Majid. I believe you didn't get into such details in your lecture. Is that right? You can just type in the chat. You didn't take the types, the complex and the compound types, right? Okay. So, now the last one is the ameloblastoma. The ameloblastoma is the second most common odontogenic tumor. We said the most common is odontoma. Ameloblastoma is the second most common. It is, again, from epithelial origin, but you have no ectomesenchymal differentiation. So it has epithelial origin, but no differentiation. It is locally aggressive, slow growing, and indolent. So it can be multicystic, unicystic, and it will have palisading epithelium. It can recur, and again, treatment is by wide resection. Let's look at the histology here. So this is the gross morphology. This is the histology. So you'll have cells arranged in a palisading way around the basement membrane. So you'll have the dark blue cells with clear parts. So the doctor described them as being piano cells. So they will be palisading. You will have blue and pale, and it will look like a piano, like piano keys, which is the ameloblastoma. Now, to remember this, I used to remember ameloblastoma as a girl called Amelia. Amelia used to play the piano aggressively. So this will remind you that ameloblastoma will have histology of piano keys, and it's an aggressive, locally aggressive tumor, as opposed to odontoma, which is epithelial origin, most common, but it's probably a hamartoma. It's not aggressive. Now, odontoma will be treated by local excision, ameloblastoma by wide resection. They don't usually ask about the treatment, but just in case, it's good to know. Now, finally, to the laryngeal and the nasopharyngeal lesions. This is the last review section, and then we'll jump off to the questions. Inshallah, after this review, the questions will be super easy. They're not a lot, so we will be done quickly, inshallah. Now, the laryngeal and the nasopharyngeal lesions. Starting off with the reactive node or the Singer's node. Now, it's a reactive, inflammatory, non-neoplastic nodule. So it's a very tiny nodule, about 1 millimeter on the vocal cords. So you will find this due to irritation in the true vocal cords, and it will lead to progressive hoarseness. So it can be sessile or pedunculated, and it may ulcerate. Sessile or pedunculated means it can either have a stalk, so it will be pedunculated, or it's directly attached to the vocal cords or the epithelium. So it's sessile or pedunculated, may ulcerate, mostly in smokers and singers. Now, so you can see, so you can tell if it's associated with smokers and singers, it can lead to progressive hoarseness. Again, remember it's tiny, it's reactive, smokers and singers, true vocal cords, irritation, and hoarseness. Now, here you can see in the histology you have a fibrovascular core and surrounded by squamous epithelium. So this is all you need to remember about reactive nodes. Now to the squamous papilloma. Remember how we said we have different types of HPV, human papillomavirus. We said we have different numbers. Some numbers are associated with benign lesions, other numbers are associated with malignant or cancerous lesions. We said squamous cell carcinoma is associated with smoking or HPV. We said in that case it was HPV 16, which will lead to cancer, squamous cell carcinoma. Here, squamous papilloma, on the other hand, it's associated with HPV 6 or 11, and it will appear like a raspberry-like growth. And in this case, it's 1 centimeter, as opposed to this one, which is tiny, smooth. This one is raspberry-like, and it's 1 centimeter. On true vocal cords. Again, it can cause hoarseness, ulceration, but carcinoma is rare, so it's usually benign papilloma only. Now, it can be in adults or in kids or in juvenile papillomatosis. Now, in adults, it's usually a single papilloma. In kids, it's usually papillomatosis, so it will appear as multiple lesions. It can recur and will regress at puberty. Now, you need to remember that this one is recurrent. So squamous the papilloma is recurrent, and in adults, it's usually single. In kids, is papillomatosis, and vertical transmission is possible, so from a mother to a child. So remember to vaccinate. Now, this is the histology. Here you have the fibrovascular core here, surrounded by orderly squamous epithelium. You have multiple like projections, which are the papillae. So this will, when you look at this, you need to recognize the stalk. You can recognize the projections, the papillae, and this will lead to the diagnosis of a squamous papilloma associated with HPV, but the other types of HPV, not the malignant ones, HPV 6 and 11. 16 and 18 are the malignant ones usually. So those are with the carcinoma. This one is a papilloma. Now, laryngeal squamous cell carcinoma. This is 2% of all tumors, and it's much more common in males, 7 to 1, male to female ratio. Again, hoarseness, pain. Hoarseness is due to affecting the vocal cords, so it's not. So you can see it's common in papilloma, in active nodes, and so on. So laryngeal squamous cell carcinoma is directly proportional to smoking and HPV. Remember, we talked about squamous cell carcinoma in the beginning. So here again, we have squamous cell carcinoma, but in this case, it's laryngeal. Again, same associations. You have smoking, you have alcohol, which causes an additive risk with smoking. So if a person is a smoker and an alcoholic, you have increased risk, an additive risk. Also, asbestos, irradiation, and HPV. Now, as we said previously, HPV has a better prognosis than smoking-associated squamous cell carcinoma. Again, as we explained previously, it will follow the same order: hyperplasia, metaplasia, dysplasia, and then carcinoma in situ, and then it will become invasive and start spreading. So it will start as thickening, and then it will progress to fungating ulcerated mass. And a localized disease will have a very high chance of survival. And here, let's look at those different presentations. So it can be glottic, supraglottic, and subglottic. So this is related to the place of the lesion as compared to the epiglottis. The best prognosis is with the glottic squamous cell carcinoma. The glottic squamous cell, laryngeal squamous cell carcinoma will have an early presentation, and it will be well differentiated because the patient presented early before the lesion started progressing and has poor lymphatic drainage. Now, supraglottic will have rich lymphatic drainage, and subglottic is usually clinically silent until very advanced. When the patient presents with a very advanced lesion, it will be a bit too late. Can anyone tell me why the glottic squamous cell carcinoma has the best prognosis? Does anyone know? No chance metastasis? No. تمام. Okay, so carcinomas are usually known. Yes, good job. carcinomas are usually known to spread through lymphatic spread. So if you have more lymphatic drainage of the area, there's more chance that the lesion can spread to other areas. So for example, here in glottic, we said it has poor lymphatic drainage. Poor lymphatic drainage means there is less chances that this cancer will spread before the patient presents. So you have early presentation, it's well differentiated, there is poor lymphatic drainage, so glottic will have the best prognosis. Meanwhile, the others will have worse prognosis because you have more lymphatic drainage of the area. And yes, this is the histology again. We said we were going to see the keratin pairs, the desmosomes, and everything with the squamous cell carcinoma. Is there a question? Okay, no question. So now finally to the nasopharyngeal carcinoma. Nasopharyngeal carcinoma, from the name, it will arise from the nasopharyngeal mucosa. The malignant part is epithelium, although the virus affects the epithelium and B lymphocytes. What does this mean? Now, in the histology, you will see epithelial cells and lymphocytic cells, or the B lymphocytes. These, both of them will be associated with infection or with the cancer. But which one is the malignant part? So you have B lymphocytes affected by the virus and the epithelium affected. But the epithelium is the real malignant part. So you need to remember this. The epithelium is the malignant part, although the virus will affect the epithelium and the B lymphocytes. Now, it's associated with EBV, again, Epstein-Barr virus. Can anyone remind me? Can you repeat why glottic has better prognosis? Okay. So we said carcinomas are they usually spread in a lymphatic spread. So you have different types. You have carcinomas, you have sarcomas, they can either spread by blood route or the lymphatic route. Carcinomas usually go for the lymphatic route. So if you have a good lymphatic range of the area, so you can imagine you have a cancer in the area, but there is high lymphatic spread, lymphatic drainage. Those cancer cells can go to the lymph nodes. They will start spreading to other areas and they will metastasize. So the patient will present, and the cancer will have already metastasized to several areas. If the cancer is in a glottic area, the glottic area will have poor lymphatic drainage. So there's less chances of the cancer to spread to other areas by the time the patient presents. Due to the poor lymphatic drainage, this means the patient will have better prognosis because it will be confined to this area. So the patient will present early. The cancer is still well differentiated. The patient will basically present because there is pain, dysphagia, which is a problem swallowing, and hoarseness, not because of the metastasis of the tumor. So due to the poor lymphatic drainage, the patient will have better prognosis, early presentation, and the carcinoma is still well differentiated. Meanwhile, if it was supraglottic or subglottic, it will have rich lymphatic drainage. So as you can see here, rich lymphatic drainage in the supraglottic area, and also in subglottic, so the cancer will be clinically silent till advanced stages. So it will start spreading to other areas. And then by the time the patient presents, it will be too late, and the chances of survival, 5-year survival rates, will be very low. Is it clear now? Now to the nasopharyngeal carcinoma. It's associated with EBV, especially type 2 and 3. It is associated with salted fish and some certain genes and geography. Now, you need to remember EBV association. So we said squamous cell carcinoma or squamous cell carcinoma is associated with HPV, and HPV, which strain? HPV 16 usually, because we said HPV 6 and 11 will be more associated with the benign lesions like squamous papilloma, HPV 16, 18 more with the malignant lesions like squamous cell carcinoma. EBV is associated with nasopharyngeal carcinoma, and we mentioned it earlier in which part? Can anyone remember? Exactly, hairy leukoplakia. So you need to remember EBV association with hairy leukoplakia and nasopharyngeal carcinoma. Now, geography-wise, it's found in South China, and you can make the connection between South China and the salted fish because of their dietary habits and the type of food they eat there. So there will be more chances of nasopharyngeal carcinoma. And in South China, it's usually the adults being affected. In Africa, it's more of the children. In other areas, you have bimodal, so it affects both the children and the adults. Now, it has different appearances. It can be keratinizing, it can be non-keratinizing squamous cell carcinoma, or undifferentiated carcinoma, lymphoepithelioma. Now, it's usually clinically silent. Location will determine symptoms. So, in the nasopharynx, the location means the patient will present with dysphagia, also hearing loss. And by the time it's diagnosed, up to 70% will metastasize to the cervical lymph nodes. So the patient will present when it's a bit too late, so the cancer metastasized, but it's radiosensitive. So radiotherapy will help get rid of those cells. So there's a 50% chance or 50% 5-year survival. Now, this is the histology. You have undifferentiated carcinoma. Sorry. You have the undifferentiated carcinoma. You have a sea of lymphocytes and epithelial cells. What did we say about this? We said the epithelial cells are the actual malignant parts or the malignant malignant part of the carcinoma. Meanwhile, you have a sea of lymphocytes here. So you have a sea of lymphocytes, and here you have the epithelial cells with no cytoplasmic margins. So you will have the nuclei with surrounding cytoplasm. So here you can see those are the epithelial cells surrounded by a sea of lymphocytes. So that is it for the general division of HNS patho. This is everything you need to know before the questions. Do you have any questions before we can start with solving the actual questions? Anything? Here. Would you like a 5-minute break or shall we start with the questions? Okay. So we'll take a 5-minute break. 8:60 inshallah. We'll be back. Okay. So now that we're done with the summary, we can move on to the questions. Now, I attached pictures of the summary here, and I can send you the PDF again if it's clearer than those pictures. Now, starting with the oral cavity questions, I'll give you some time to type your answers in the chat, and then we discuss every question together. Question 1. You have a 55-year-old woman who notes a nodule while rubbing her tongue on the side of her mouth. On physical examination, there is firm, non-tender nodule covered by pink buccal mucosa at the bite line. The region is excised and does not recur. What is the most likely diagnosis? We have these. Some other answers. Okay. Okay, we got a few B's. So, okay, the correct answer is B. This is a straightforward question. The keyword in this case, 1 second. Here. The keyword in this case is the bite lines. So you can see it's a firm nodule. It's a very small nodule, and at the bite lines, and when excised, it does not recur. So this is the typical presentation of a fibroma. And we said it's more common in females, and she's a 55-year-old, so this is the most common presentation of fibroma. Now, this is the summary from the table. So this is due to continuous irritation, most commonly active inflammatory growth, and this is its appearance. Question 2. 25-year-old man notices several 0.3 centimeter clear vesicles on his upper lip after a bout of influenza. They rupture, leaving shallow ulcers that heal over the course of 10 days. 3 months later, after a skiing trip, similar vesicles develop with the same pattern of healing. Which of the following microscopic findings is most likely to be associated with these theorems? Here we got an E. E. Okay, those who picked E, can you tell me your diagnosis? HSV. So correct answer is E, internuclear inclusions. And as you guys said, it's HSV ulcer. So you can see the patient had influenza, and then he had some vesicles which ruptured and left some ulcers. And then it became latent. And then after several months, it developed again with the same pattern of healing. So this is the typical presentation of an HSV ulcer, the herpes simplex virus ulcer. And we said there are three main things to remember in HSV. You have multinucleation, molding, and margination. As we said, this is the typical presentation of HSV ulcer. In this case, you have intranuclear inclusions. So these are the intranuclear inclusions in the HSV ulcer. Now, next question. 42-year-old man has had a constant bad taste in his mouth for the past month. On physical exam, there are white fluffy patches on the sides of his tongue, cannot be scraped off. The biopsy is taken on the microscopic examination, squamous epithelial hyperkeratosis, parakeratosis, and choriocytes. IHC staining for EBV is positive. Which of the following is the most likely factor for his organism? You have some C's. What about the rest? Those who picked C, can you give me your diagnosis? Leukoplakia. Okay. Correct answer is C, HIV infection. And what led you to picking leukoplakia as the diagnosis? Can you tell me? What is the keyword in the question? Okay, EBV, correct. So we have EBV and non-scrappable, correct. And one more thing. White fluffy patches on the side of the tongue. So for the appearance, the gross appearance, you have white fluffy patches on the side of the tongue. We said this is leukoplakia, and there is EBV positive, and it's non-scrappable. Which one was scrappable? Can anyone type in chat? Yes, Candida is the scrappable one. Leukoplakia is due to EBV, so it's seen in HIV patients. It's not pre-malignant, and it's unscrappable white fluffy patches on the tongue border. 58-year-old man, cigar smoker, visited his dentist for routine dental examination. Lesions with clinical and histological appearance, as you can see in the pictures. No major medical problems. Which of the following etiologic factors most likely contributed to the development of those lesions? We got one E. Okay. So, those who picked E, what is your diagnosis? Why did you pick E? E is the correct answer. Just give me the diagnosis. We got squamous cell carcinoma. Is the tongue ulcerated? Now, this won't really help you with the diagnosis, the ulceration. So, تمام. Okay. Now, yes, the correct answer is smoking tobacco. It is squamous cell carcinoma. Now, let's look at what we said here. Now, we said squamous cell carcinoma. Here, wait, let me go back to the original table. Here. 1 second. Down. So this is squamous cell carcinoma. We said it's associated with smoking, tobacco, and HPV-16. Now, squamous cell carcinoma is associated with smoking, tobacco, HPV-16. In this case, we said the patient is a smoker. So the main concern here is that he's a smoker. And let's go back to the question. Sorry. Going back to the question here. For the other choices, we have chronic sialadenitis. We said sialadenitis is basically inflammation due to destruction in the salivary glands. So this will have nothing to do with this presentation, the oral lesion, because we said the sialadenitis will appear as a mucocele that will fluctuate with the meals. Dental caries will affect the teeth themselves. It won't really present with this presentation in the tongue. Eating smoked food has nothing to do with anything we explained so far. Now, we also have the herpes simplex virus type 1. We said HSV is associated with the 3 M's, the margination, multinucleation, and molding. And the presentation will be an ulcer that will become latent. And then after some time, it will get reactivated when the patient has an infection, for example, or any viral infection, for example. It will get reactivated and will appear again as ulcers. In this case, the case is squamous cell carcinoma case, and this will be associated with smoking tobacco. What is the other risk factor we set for squamous cell carcinoma other than tobacco? It wasn't HSV, it was HPV. Exactly. So we have HPV. We said we have different types of HPV. Which one is associated with the squamous cell carcinoma? Yes, 16. HPV-16 is associated with squamous cell carcinoma. Now, for the next question, 74-year-old man with 15-year history of diabetes is hospitalized because of end-stage kidney disease. Tongue, inner side of the lips, buccal mucosa are covered with white, slightly elevated soft patches. What is your diagnosis? C. Now, those who picked C, why do you think that is the answer? Okay, have diabetes. Do the rest agree with this answer? An A. Okay. So we have 2 C's, 2 A's. C. Ta. Okay. There's a question again. Another C. Ta. Correct answer is C. That's A. Immunosuppression. Exactly. That's the key word here. So we have a 74-year-old patient. He has 15 years of diabetes. He's hospitalized and has end-stage kidney disease. So since he's hospitalized, he has several chronic diseases. The patient is immunosuppressed. So he is the perfect candidate for any infection for example, in this case, we have Candida. This will affect the immunocompromised patients. So fungal infections will affect immunocompromised patients. What did we say about leukoplakia? Can anyone remind me what we said about leukoplakia? What is the most important risk factor for leukoplakia? So we got tobacco and smoking. So in this case, we don't see any smoking tobacco, although both of them are white patches and they appear in the oral cavity. In this case, they didn't say anything about it being scrappable or unscrappable. So if they did have unscrappable, it will lead to leukoplakia. Scrappable will lead to candida. But in this case, our main concern is the presentation of the patient. So the patient is immunocompromised, diabetes, hospitalized, end-stage kidney disease. Meanwhile, leukoplakia, the patient would be, for example, a 50-year-old man who is a chronic smoker and has white unscrappable patches on the tongue. Now, last question in this section. A 17-year-old girl noticed small, sensitive, gray white areas forming along the lateral body of the tongue 2 days before the end of her examination. On examination by the physician assistant, the girl is afebrile, shallow ulcerated lesions, erythematous. Therapy is given, the lesion disappears in 2 weeks. does not use tobacco or alcohol. What is the probable diagnosis? A. We got a few A's. Okay, so this is an easy question. This is an athlete's ulcer, which is the most common one. We said it's a shallow ulcer with hyperemia, which is linked to stress levels and vitamin deficiencies. So here you can see it's a 17-year-old girl, 2 days before the end of her examination, and it's a shallow ulcer, and this occurred within 2 weeks with minimum therapy. There's no specific therapy. So this is the very simple case of an athlete's ulcer. Now, the salivary glands. Um, do you guys need a break or we can just continue? No. Come on, تمام. Continue. طيب, salivary glands. A 40-year-old woman presents with painless mass anterior to her left ear. The mass has been slowly enlarging over the past year. The mass is firm and non-tender. CT and MRI reveal well-circumscribed homogeneous mass within the left parotid gland. Biopsy reveals anastomosing strands of cellate and fusiform epithelial cells embedded in myxoid stroma. What is a characteristic of this lesion? An answer? That would be other answers. Part 1B, 1D. And E. 10. More answers. Another B. More B's. So, okay. Let's take this case word by word. So, the patient presenting is a 40-year-old woman. Painless mass anterior to her left ear. Slowly enlarging, firm and non-tender. So far, we don't have anything specific. Now, it's well circumscribed within the left parotid gland. So, number one, it's in the parotid gland. So, keep that in mind. What did we say about the neoplasms? What did we say about the neoplasms in the parotid gland, in the salivary glands in general? We said the smaller the gland, the more chances that it's malignant. So this one is in the parotid gland, so more chances of it being benign than malignant. So this way, okay. So let's start solving by exclusion. A. Papillary cystadenoma lymphomatous, that word, anyways. We can scratch that because we didn't take anything about this. Most often localized to submandibular gland. We said this is in the parotid gland and it's anterior to the left ear. So this is in the parotid gland. It is the most common malignant salivary gland tumor. We said parotid gland, big gland, so it's not malignant. It's usually benign. Now, between D and E. Again, since we said it's not malignant, so we can remove E. Recurrence often takes place after surgical resection. What is the case? What do we have here? So we have stellate, fusiform epithelial cells, myxoid stroma. So we have different phases. We have different appearances in the histology. So this is pleomorphic adenoma, exactly. So the correct answer is D. Recurrence often takes place after surgical resection. Can anyone remind me why recurrence takes place? We discussed this. And because of recurrence, we have to take a wide section to make sure. Exactly. So we have tiny extensions from the capsule. So this is a pleomorphic adenoma. So it's benign, but there is high recurrence. You have myopithelial cell with divergent differentiation. You have microscopic extensions from the capsule, so you need to do wide resection. So the correct answer is highly recurrent, and recurrence often takes place after surgical resection. This is the pleomorphic adenoma case. Question 8. 60-year-old woman, bump beneath her tongue, does not smoke or use alcohol. There's a movable submucosal mass in the minor salivary glands and buccal mucosa. Excised mass showed that it is malignant and locally invasive. Tumor recurs in 1 year. Which of the following is the most likely diagnosis? Cut B. Okay. Correct answer is B, mucoepidermal carcinoma. Can anyone tell me why it's not pleomorphic adenoma? Yes, it's malignant. We said pleomorphic adenoma is usually benign. Mucoepidermal carcinoma is malignant. And why is it not squamous cell carcinoma? What does it? It's not squamous cell. What did we say are the most common risk factors for squamous cell carcinoma? Is smoking and alcohol. We said this patient does not smoke or use alcohol. There's a bone beneath her tongue, so it's in the salivary glands. In this case, we have a mucoepidermal carcinoma, which is a neoplasm, the most common malignant one. You have squamous mucus secreting cells, and the tumor involves the facial nerve. Question 9. 45-year-old woman, 1 year history of dry mouth and eyes. Infiltrates of lymphocytes, local germinal centers. What changes would be expected of a patient's fertile gland? Okay, before answering, what do you think the diagnosis is? Woman, 45 years old, dry mouth and eyes. What is this case? Okay, Sjogren syndrome? No, it is Sjogren syndrome. What happens in the parotid glands later in the course of the disease? Any guesses? Gland destruction? Okay, the gland is destroyed. So what exactly happens? Is it hyperplasia, hypertrophy, atrophy? Okay, so correct answer is atrophy. So here we have, as someone mentioned in the chat, you have antibodies, you have autoimmune destruction, the gland will start to atrophy, and the glands being the salivary glands, the lacrimal glands, and everything. In this case, it's the parotid gland, I think. Yes. In this case, it's the parotid gland. Typical presentation is female in her 50s, in this case, 45-year-old woman. So this is Sjogren syndrome because we have dry mouth and eyes, conjunctivitis sicca, and xerostomia. And what happens is atrophy of the glands. 45-year-old woman again, long-standing rheumatoid arthritis, dry eyes, dry mouth, bilateral enlargement. The syndrome described here is best described as, yes, this is an easy one. It's an autoimmune disease. Again, the diagnosis is Sjogren syndrome. In this case, the answer is autoimmune. Again, I explained that. If you have any questions, please let me know. Moving on to dental diseases, the last two sections. Inshallah, they won't be too long. Do you have any questions before moving on? So, dental diseases. 19-year-old woman. swelling in the back of your mouth for 2 months, area of swelling in the location of the third molar, left third molar, radiolucent unilocular worse circumscribed cyst around the crown of unerupted third mandibular molar. Cyst lined by stratified squamous epithelium, surrounded by chronic inflammatory infiltrates. Wait, that's a B. Others? E. Any other answers? We got B and E so far. Mm. No, correct answer is B, dentigerous cyst. Again, let's answer by exclusion. Ameloblastoma. What did we say about ameloblastoma? Yes. Said ameloblastoma, the one with the piano-key appearance, so it has tamam. So ameloblastoma is the one with the palisading cells on the histology. We said it's aggressive, so it's malignant. And so this is associated with the neoplasms. We said we have odontoma and ameloblastoma, which are the tumors. Odontoma, what did we say about odontoma? We said odontoma is probably a hamartoma. So we said, what did we say about odontomas? Yes, we have the enamel and dentin deposition. So we said it is of epithelial origin, but we have haphazard deposition of the enamel and the dentin, so it's probably a hamartoma. So these two are mostly tumors. In this case, we're talking about a cyst. So what are the cysts in this case? We have dentigerous cyst, odontogenic keratocyst, and periapical cyst. What did we say about periapical cyst? Periapical, so it's near the apex. So it's near the apex of the tooth. In this case, you have it's surrounding the crown of the unerupted third mandibular molar. So we said the periapical cyst is around the apex of the tooth. Now for the odontogenic keratocyst, or the keratocystic odontogenic tumor, what did we say? What is the location of odontogenic keratocyst? Yes, the posterior mandible. Odontogenic keratocyst is near the posterior mandible, and the dentigerous cyst is the one left, which is the one surrounding the crown of the unerupted third molar. So dentigerous or follicular cyst is a developmental cyst. It's the most common developmental cyst around the crown of unerupted tooth, especially the third molar. Yeah. In my case, 90-year-old man, swelling left side, painless swelling in the left posterior mandible. Circumscribed multilocular cyst of the left mandibular dermis. Cyst lined by stratified squamous epithelium with prominent basal layer. No inflammation of granulation tissue. Here I got to see. تمام. See. Correct answer is odontogenic keratocyst. I just said the keratocyst is the one at the posterior mandible. So this is straightforward again. OKC or keratocystic odontogenic tumor associated with basal cell carcinoma, location at the posterior mandible. It is aggressive. And as we said, we have thin keratin layer, prominent basal cell layer, and corrugated epithelial cell surface. 64-year-old man presented with sores on the gums. Oral examination shows multiple gingival abscesses adjacent to the teeth and excessive mobility of several teeth. Which of the following is the most likely diagnosis? Yes, this is an easy question. Periodontal disease is we said in gingivitis you have inflammation of the gums, so you'll have edema, bleeding, and so on. In periodontitis, you will start to have loosening of the teeth because of the destruction of the ligaments, the cementum, the tooth itself. So you will get the periodontitis. So in this case, the correct answer is periodontitis, as compared to gingivitis, as you can see here from the summary table. Caries is basically due to the acidic products of the bacterial fermentation, so it will form only a biofilm. It won't cause the destruction of the tooth. And one point worth mentioning is when the patient presents with pain. So if it's just a biofilm on the surface of the tooth, the patient won't feel any pain. If it starts invading into the dentin, there will be some irritation, and the real pain is felt when the cavity reaches the pulp. So the pulp is where the nerves are. So when the cavity reaches that location, patient will start feeling severe tooth pain. Now, quick review. We have different sentences, and I want to give me the name of each one. So number one, around the crown of unerected tooth, especially third molar. What did we say is the most common one? Around the crown. Lentiginous, thyroid, around the posterior mandible and associated with basal cell carcinoma. Yes, odontogenic keratocyst or the OKC. Now, the most common odontogenic tumor, which is possibly a hamartoma. Again, it's the most common odontogenic tumor, but not the most common malignant one. Yes, odontoma. Now, a locally aggressive odontogenic epithelial origin with no differentiation. Which one is the aggressive one? Mm-hmm. Ameloblastoma. تمام. And finally, which one is at the root or the apex of the tooth? Apical something, periapical granuloma. Yeah. It's also called the radicular or the periapical granuloma. Now, as I mentioned, you need to know all the names for each of them. So, for example, dentigerous, you need to remember that it's also the same as the follicular cyst. Now, all the answers are correct, as you guys mentioned. And for the last one, remember that the periapical granuloma is the same as the radicular cyst. Now, finally, for the larynx and the nasopharynx. Let's start. We have a 63-year-old male, 80-pack-year smoking history, diagnosed with laryngeal tumor. His physician informs him that he has an excellent prognosis. Of the following choices, what was the most likely tumor type and what was its location? Mm-hmm. We got 7 Bs. Correct answer is B. So it's a squamous cell carcinoma. We did not mention adenocarcinoma in this review. So the most common in the laryngeal and the nasopharyngeal tumors is the squamous cell carcinoma. And you said the best prognosis is the So the best prognosis is in the glottic region. We said this is due to. Can anyone let me know? Yes, poor lymphatic drainage of the area. So poor lymphatic drainage in the glottic area results in early presentation with well-differentiated tumor and the best prognosis. تمام. A 6-year-old boy increased difficulty breathing, and the character of his voice has changed over the past few months. 3 soft pink excrescences on the two vocal cords and in subglottic region. 1 centimeter in diameter, excised nostrils, finger-like projections of orderly squamous epithelium overlying fibrovascular core. Immunostaining for human papillomavirus 6 antigen is positive. Based on these findings, which of the following statements is the best advice to give the parents of this boy? Letter D, letter C. تمام. طيب. No. Again, by exclusion. Total laryngectomy is necessary. We never mentioned this. You do not need to get rid of the whole larynx. Congenital heart disease may be present. Again, we did not mention this anywhere. So now it's between C, D, and E. Therapy with acyclovir is indicated. This is indicated for viral diseases. So any viral infection will you'll give acyclovir. So this is usually for herpes, for example. In this case, it's not herpes infection, so this has nothing to do with it. Again, we can exclude E. Now between C and D, we have C. The boy should not overuse his voice. D. The lesions are likely to recur. Not overusing the voice is associated with which lesion?
Recording in progress.
Now, C, not overusing the voice is associated with a reactive nodule or a Singer's node. D, the lesions are likely to recur, is associated with the squamous papilloma. Now, in this case, what is the presentation? Yes, exactly. So this is a papilloma case. We said the excised muscle shows finger-like projections or there is squamous epithelium with a fibrovascular core. So the correct answer would be D. The lesions are likely to recur. So this is the case. We said it is also associated with HPV 6 or 11, which is for the more benign lesions. In this case, we said immunostaining for HPV 6 is positive. So here, HPV 6 positive. It's at the two focal cords. We said it can recur, as we said. Here you can see it's a 6-year-old boy, and this kid has 3 soft pink excrescences on the two vocal cords. So this is a juvenile papillomatosis case, which can recur, and it will regress at puberty. And as they described in the case, there's a fibrovascular core and finger-like projections. So this is a squamous papilloma case. Meanwhile, for a reactive node or a Singer's nodule, you'll tell the patient not to overuse his voice. Okay, 33-year-old man from China presents with a lump in his neck. Physical exam reveals painless anterior cervical adenopathy. Large necrotizing mass is identified in the posterior nasopharynx with obstruction of both eustachian tubes. Biopsy of the mass reveals sheets of malignant cells with large nuclei. Which of the following pathogens has been associated with the development of the patient's neoplasm? We got to see. The answers. B. So, can anyone tell me the diagnosis in this case? So there is a lump, there is cervical adenopathy in the nasopharynx and obstruction of the eustachian tubes. So this is a case of nasopharyngeal squamous cell carcinoma. Exactly. Nasopharyngeal squamous cell carcinoma. Now, what did we say is the main association in this case? It's ABV. We said EBV is important in two cases in HNS. We said nasopharyngeal squamous cell carcinoma and also very leukoplakia. HSV, we mentioned herpes in the three M's, in the margination, molding, and multinucleation, which is the ulcers that can recur and because the virus is latent in the nerves. Now, in the case of the squamous cell carcinoma, laryngeal squamous cell carcinoma, the main associations will be smoking, tobacco, alcohol, and HPV. In this case, nasopharyngeal one is associated with Epstein-Barr virus, EBV. So this is from the summary. It's associated with EBV, salted fish, genes, and geography, like South China, which is mainly associated with adults, and Africa, mainly children. Other areas are bimodal. We said nasopharyngeal carcinoma will have both epithelium and B lymphocytes affected. The malignant part, though, is the epithelium. Now, next question. 54-year-old man, non-smoker, non-healing ulceration at the base of his tongue on the right side for 2 months. On examination, this lesion is 1 centimeter in diameter with irregular borders. A biopsy of the region performed and microscopic examination shows infiltrating squamous cell carcinoma. Which of the following infectious agent is most likely to be associated with this lesion? We repeated this 1,000,000 times. Any answers? C. تمام. Correct answer is C. HPV. Which HPV strain is associated with squamous cell carcinoma? 16. Yes. So 6 is for the benign ones, which is the squamous papilloma. 16 for the malignant ones, like squamous cell carcinoma. This is the case, the laryngeal squamous cell carcinoma associated with smoking, alcohol, and HPV. Now, the last question. I have 28-year-old man. I hid this profession because it's very obvious. Now, hard times for the past 3 years. What about 11? We said 6 and 11 are associated with papilloma. 16 and 18 are the malignant ones for squamous cell carcinoma. So, now back to the question. Okay. The voice quality has become progressively hoarser, afebrile, no palpable masses, does not have a cough or significant sputum. Advice on previous visit to give up smoking. Which of the following is the most likely to produce these findings? B. Seven. So we got a D. Now if I reveal what is in this box. So the patient is a singer or a songwriter. What is your answer now? C. تمام. Other answers, does everyone agree? Yes. So this is a case of the active nodule. The patient is a singer and he's also advised to give up smoking. So he has both important risk factors, singing and smoking. So this is the case. We said it's a reactive or singer's nodule, mainly in smokers and singers. It is a reactive, non-inflammatory, non-neoplastic nodule, which is very tiny on the two vocal cords. And you can see the patient's voice quality has become progressively hoarser, and he is afebrile, no palpable masses in the head and neck area, does not have a cough or significant sputum production, so it's not big and obstructing. So it's small and only causes hoarseness because it's affecting the two vocal cords. And since he smokes and he's a singer, so this leads us to a diagnosis of the active nodule. And that is it for my session. Thank you so much for attending. If you have any questions, please do not hesitate to contact me. You have my contact information. And here's a QR code you can scan for the team. Any questions? I hope you guys benefited. Thank you so much. And if you have any questions, you can contact me. Have a nice day, everyone.